Okay, yeah, thank you. Thank you very much for the kind introduction, Professor Kim. Good to see you. Um, I have heard very good, excellent talks so far. It was a pleasure listening to them. And I note it's a lifelong learning. My topic is a little bit off the road, but I hope you will enjoy it. I would like to introduce you the ACURATE NEO2, which is new in the market in Korea. And yeah, we focus on patient selection, some tips and trips, and probably less of troubleshooting. In my disclosures, there are different generations. We first started with the ACURATE transapical system back in 2012, which is not available anymore. Then in 2014, we received CE mark for the ACURATE Neo. And a few years ago, the ACURATE Neo2 came into the market with only slight modifications. You see the increased skirt to treat PVL and radio pack marker. Everything else is basically the same. There are new developments upcoming. Here's a short video showing the implantation steps for those that are less familiar. You can see that the upper crown is open during step one, and then followed by opening of the stabilization arches in step one. Then you verify the procedure and can open the lower crown for full deployment. And usually this can be done on beating heart. I prefer to use fast pacing, sometimes rapid pacing. I'll explain later on. And I would like to start with patient selection. And I think it's important in general if we look for the best choice for each patient to look at different criteria. Of course, there are anatomical limitations. There are some valves that cannot be used in all patients only due to anatomical limitations, for instance, annulus size, etc. I think the highest priority always should be to achieve a good immediate procedural outcome. That includes safe implantation, safe deployment. We should go out of the procedure with no more than mild PVL. We try to achieve good gradients. We have talked a lot about it, and we should choose the valve with lowest coronary obstruction risk. And I think if you have two similar valves with expected similar outcomes in terms of good procedure, then you can start to think about future aspects, lifetime management, future coronary access, tough durability, explantation, etc. So I think you can have a good future coronary access, but if you are not able to achieve immediate good outcome, then it's quite useless. And for the ACURATE Neo, because it's new, I think it should be important to look at the strengths, but also at the limitations. I've highlighted some of the strengths. I've made experience in the past, but also limitations. And we know that the main limitation is next to the valve size availability. We can only implant up to 27 millimeters. Higher valve sizes are underway. But I think the greatest limitation is that in cases with very severe aortic valve calcification, and especially with eccentric calcification, there is some there's a downside to use the ACURATE Neo due to incomplete expansion and higher risk of PVL. I think this is the greatest limitation that we should take into account. Of course, with the skirt of the Neo 2, the rate of PVL has massively dropped, but still I still see in very eccentrically calcified anatomies, there's still a higher risk of PVL. Let's start with some strengths. We all know that in horizontal aortas, it's difficult to implant with long stent frame valves. This is no problem for the ACURATE Neo due to its self-alignment and the stabilization arches. This has also been shown in a large registry showing higher device success compared to the Evolute. system. And also due to the very flexible system, you will never see any problems in crossing the arch. You will never have to use a snare in order to cross the aortic valve. And this is due to the very flexible system. We talked about gradients, which is also important for long-term outcomes. And we know that due to the supraannular design, the risk of prosthesis mismatch is lower, especially in smaller annuli, as shown in this comparative case example. We have a very low risk of coronary obstruction. I've shown you the rates of coronary obstruction of different registries, and this is also our institutional experience, which is quite low. And I think the main reason is that we try to select the best valve, and we have a relatively high proportion of ACURATE. And this may be a reason. Here's a case example with a very low-lying left coronary artery, and showing this comparison of what happens with the leaflet. When you look at the sapien, then you can see what happens with the leaflet and calcification, which is pressed just in front of the coronary ostium, whereas with the ACURATE, the upper crown is keeping away the calcification from the coronary ostium. This is a quite atypical implantation. Also, we know that permanent pacemaker rates are relatively low. As you can see here, there are different numbers shown here. I think you should all be familiar with those. Of course, permanent pacemaker is a multifactorial aspect. And when I was in Korea, I was surprised to hear about relatively low pacemaker rates, because the threshold probably is much higher to implant a pacemaker than in other countries. The ACURATE nevertheless has relatively low pacemaker rates, probably currently lowest pacemaker rates of its class. And I think one reason is the specific distribution of the radial force, which is relatively high here, where we aim to implant the valve, and the inflow part here, which is in the LVOT, has a relatively low radial force. So for the ACURATE valve with a nominal positioning, we will have good outcomes. There's no need for intentionally high positioning. We only need to avoid deep positioning. I'll talk about positioning a little bit later. TAVI explantation will be also important subject. There are different registry data out there, a little bit difficult to interpret. This is my personal perspective of TAVI explantation. I think it really depends also on the design of the valve and several other criteria. Valve-in-valve, this has been talked about extensively here. There are different options also for the ACURATE. And I think it's important to note that for the ACURATE, there is a VTA of 2 millimeter by default, as you can see here, because usually between the stent post and the leaflets and the upper crown, there's a space of 2 millimeters. So probably there is a relatively low risk of coronary obstruction when you insert a second valve. And we have seen this in numerous valve-in-valve implantations that we did as bailout for malpositioned or leaking prosthesis without doing commercial alignment or basilica. And actually, we've never seen coronary obstruction because of this specific design. Also, here's an example of what is possible in terms of valve-in-valve. Here's a implantation that we did actually as an emergent case with gymnast stenting, so there was no time for to consider basilica. And you can see we implanted the chimney stand just right here, and we were able to re-enter the stand with the wire after the wire had been retrieved. You can see the result here. And we were able to really re-access this chimney stand. So maybe this a little bit different approach of a chimney stand and might change the view on it. So I would like to show you some slides on how to best position, and the marker band thing that came up with the Neo2 is a blessing and a curse the same, because I think it really helps for the initial positioning, but it is important for you to not rely exclusively on the marker band alone, and I will show you why. You should always look at the relation between the upper crown and the calcified leaflets. This is the basic thing, and here in this example, I think you're way up too high and need to adjust the position. So I have shown some scenarios. If you have a so-called concurrent aortic root, then if the marker band is here just in the line annular plane, then you will have acceptable position of the upper crown in relation to the leaflets. And even if the positioning marker is a little bit higher, just on top of the annular plane, then you will see that there's a good relation of the upper crown with the calcified leaflets. However, this is obviously too low, both with the marker band and with the upper crown. And here you can see that we are obviously too high, both with the marker band and the upper crown. However, if you have a relatively large aortic root, then you can see that relying on the marker band alone may be misleading. And here, in this scenario here in the concurrent aortic root, this may be okay, but you can see that you may end up too low with the upper crown and have a higher risk of embolization into the left ventricle. So I think this is really dependent on the individual anatomy. Please look at both the positioning marker and the upper crown. Here's a very nice example, as you can see. And if you look at the positioning marker, we are way too high, but you can appreciate that the upper crown is already lying on the calcification. There is no way to go deeper with the valve. And you can see it's here. If you would only look at the marker band, then you would say it's way too high, but you can see there's no other option. And in such cases, if we are not sure about or not happy with the positioning, then we are very generous to employ either fast or even rapid pacing, because this improves the stability massively. If you have, you need some forward push or forward pressure, and here you can see what could happen if you don't have sufficient forward pressure. And this is very difficult to measure, actually. And here on the left-hand side, you see appropriate push. You can see that the delivery system is in the outer curvature, and the stent holder moves to the LV after deployment. On the right-hand side, you see what happens if you push too much. This is a very hard push. And actually, this is also very difficult, but it's possible. And my personal opinion is, if you get too high, then you should really initially start to adjust the position. Don't wait until step 1 is complete. I think it's important to have immediate adjustment. You see this upward movement during step 1 quite frequently. And here's also a very nice example that we had recently. During step 1, we are still fine with the position. And you will note that during opening of the upper crown, the valve is moving higher and has ended up very high. This is too high. And what we did over around 1 or 2 minutes, we slowly built up push, and were able to correct the position into an acceptable pre-deployment position and achieve a good outcome. So it's really important to take time. The push needs some time to translate into the position, especially if you have a lot of tortuosity or calcification. Finally, I would like to show you some new data that we did here. Comparison of 3-CUS versus CUS overlap view. For the ACURATE NEO, it's important there is no big difference. You can use both views if you are familiar with the different views. The technique might be a little bit different, but this is because the ACURATE has a predetermined positioning, which is completely different than other self-expanding or even balloon expandable devices. This is very fresh and is just submitted data, which maybe shows for the first time the hemodynamic and functional impact of commercial alignment. This is data from 3 centers, Rick's, Lucerne, and our center, and we show that there is some effect on hemodynamics and more aortic regurgitation if you have commissural misalignment. Finally, this is also submitted data comparing ACURATE versus Evolute, which is probably the workhorse in most centers for valve and valve TAVI. We did propensity matching, showed there's no difference in most outcome parameters, a little bit better in terms of pacemaker. So if you use ACURATE valve and valve, there's literally no risk of pacemaker implantation. I would like to summarize. I think it is in our responsibility to have a optimized selection for the patient. And regarding the ACURATE, I recommend to use mildly to moderately calcified aortic valve. You can implant the ACURATE also in severely calcified valves if the distribution of the valve is symmetric and if there's no eccentric calcification. There's probably the lowest risk of coronary obstruction and relatively easy coronary access. I've shown you that there's a low risk of conduction disturbances due to the distribution of the specific radial force without the need to implant too high. And I think I would like to highlight that, of course, high positioning is good in terms of pacemaker rate and hemodynamics, but you may have to pay a price in terms of coronary access, future TAV in TAV, and this has to be weighed, I think. Commercial alignment is easy, and I think the ACURATE could be considered as component in lifetime management. For positioning, please use both the marker band and the upper crown. Immediate adjustment in case of upper movement, and there's the need for sufficient appropriate forward pressure, and in uncertain situations, considering fast or rapid pacing. Thank you very much for your attention.